So I've heard a lot about how wonderful our next speaker is from a mutual patient of ours, but I've only just met her today. So Associate Professor Andrea Henden is a clinical haematologist and bone marrow transplant physician at the Royal. She's a clinical interest in transplantation and cellular therapies and the infectious complications of these treatments. She's also a research officer in the Translational Cancer Immunotherapy Laboratory at QIMR Berghofer Medical Research Institute. So Dr. Henden will now discuss her research into the role of fecal transplantation for graft-versus-host disease. Thank you.
So thank you so much for having me. And I feel like others, I have to declare that, look, I'm clearly not an infectious diseases physician. I'm merely a haematologist. And I'm really here to talk to you about some of my own efforts to really translate what the wealth of knowledge we have about the role of the microbiome in health and disease into actually having effective therapeutics. So my PhD was very much T-cell immunology driven, and it was right when sort of all these seminal papers were coming out and making these important links between health and disease and the microbiome. But at the time, the problem was we really couldn't do anything about this. So that's really been sort of a focus of a lot of my work, and this is one piece that fits into that puzzle. And equally, as a cancer immunotherapist, I think something that we have to understand is while we have this wealth of knowledge in bone marrow transplantation, in fact, the same T-cell driven mechanisms that we rely on for solid organ immunotherapy, and now when we've seen the absolute flourishing of CAR T and more specific T-cell therapies, that these mechanisms are probably going to be relevant to that much broader audience. And so we really need to have some therapies that can leverage the role that the microbiome has in influencing these treatment outcomes. So luckily, I don't need to spend a lot of time explaining how we do an allogeneic transplant, but I think, as Hannah has pointed out, there's a really few key steps where we think that this dysbiosis starts to be affected. Certainly the high-dose chemotherapy and radiotherapy that we give to a lot of our recipients before, as conditioning, then the move to give obviously high-dose immunosuppression, as well as the engrafting donor immune system, all drive both local damage to the microbiome and to the mucosa, and then also the systemic immune suppression that persists afterwards. And I do like to make the point that I think there's been a really revolutionary change in the way we actually do graft-versus-host disease prophylaxis in the last sort of 3 years, where in fact most centres in Australia are now moving to post-transplant cyclophosphamide as an alternative strategy for graft-versus-host disease prophylaxis. And there's a little bit of a caveat to that, in that I think what we're already understanding, and there's some data to say that in fact the role and the impact of the microbiome in transplants that are T-cell depleted in fact is probably more moderate, and post-transplant cyclophosphamide actually, so far as we understand it, really does mimic a lot of the ways of T-cell depletion. So I think there's a few caveats actually to how we understand the role of the microbiome in the various different transplant outcomes, and that's something I think that we just need to take a lens on. And what we really hope, I think, will unravel that is to really try and refine some of these understandings between the links between the gut and systemic immunity. So Hannah's already showed this slide. This is why we care about it. It's obviously the diversity of the microbiome is a big factor in terms of the transplant outcomes, which are not just driven by graft-versus-host disease, but also by infection and relapse and other non-relapse mortality. And while most of the studies you'll see do use overall diversity as the most often measured sort of endpoint, I think we really are moving to a point, and we've even seen, as I'll show you soon in some of our small case series, that there is increasing appreciation for the roles of specific species. So this is from a really nice review a few years ago, obviously showing the bacteria that are associated with known deleterious outcomes after transplantation, but there are also positive associations as well with improved clinical outcomes. And so starting to unpick this and understanding what specific microbes are important, I think, has been the driver behind, as Hannah alluded to, some of the groups that are really looking towards sort of bespoke, crafted pathogen microbiome products. But graft-versus-host disease is really where most of this data lies, and why do we worry about that? It's probably one of our most feared complications early in the acute period after bone marrow transplantation. So we somewhat arbitrarily divide acute to the complications occurring in the first 100 days after transplant. It really can affect any organ system, but the gut is one of the more commonly affected organs, and that probably relates to both the local mucosal injury induced by conditioning, as well as the broad spectrum use of antibiotics and disruption of the microbiome from those mechanisms. And we understand that a lot of the initiation of graft-versus-host disease is actually to do with direct presentation of pathogenic antigens onto antigen-presenting cells that are participating in a de novo alloimmune response once you've given the recipient the donor cells. And the problem with acute graft-versus-host disease, particularly of the gut, is it is very treatment refractory. So steroids are our frontline therapy. That works for about half of patients, but for those who don't respond, another half of them will subsequently die of that complication. We've had some sort of breakthroughs with the availability of ruxolitinib as a Janus kinase inhibitor, which will reduce T cell function, and that does salvage a number of our patients, but it's certainly not particularly effective in acute graft-versus-host disease of the gut, and so there really does remain a lot of unmet need. So we've already seen some nice slides that really do show us that FMT is an effective way to restore microbial diversity and hopefully undo some of these negative effects that the post-transplant dysbiosis can have on transplant outcomes. And so a couple of years ago, I wanted to be able to offer that to our patients at the Royal Brisbane Hospital. So we had a small pilot study that was funded by the RBWH Foundation and was made possible through a partnership with Lifeblood, who also have a stool bank. There is a GMP qualified toilet in their donor centre in Perth. And so in terms of being obviously a partner in stem cell transplantation for a long time, they were a natural partner then to look for this pilot study. And I think one of the advantages and what we're increasingly understanding in terms of selecting donors, some of the initial reticence to use FMT in a heavily immune suppressed population was due to case reports of fatalities where multi-resistant organisms had unfortunately been transferred as part of the fecal transplant. And so one of the strengths of partnering with Lifeblood was, in addition to the relatively strict VT process for blood donation, that there is extensive screening for antimicrobial resistant organisms. So this certainly seemed to be an appropriate product to use in our patient population. As Hannah mentioned, we were, though, due to that concern about potential infectious risk, relatively cautious with how this pilot was designed. It really was chosen to be only a single dose of FMT for patients who had already been identified as high-risk steroid-dependent and steroid-refractory graft-versus-host disease. We chose to use the nasoduodenal route of administration because the other risk in this patient population has been due to aspiration. So placing a nasoduodenal tube obviously required some partnership with the gastroenterology team here, but they were happy to be on board. We had considered, a lot of case series will look at colonoscopic introduction of the FMT product, but knowing the distribution, we actually see that a significant number of our patients will have small gut involvement with GVHD. We wanted to make sure that we would provide an administration route that would hopefully seed the whole bowel, not just the colon. So small pilot, we just treated 9 patients, but actually saw relatively pleasing, I think, clinical outcomes for, as I said, this fairly modest one-time intervention. So we saw that we had an overall response rate of about 55% in the first 7 days after transplant, with most patients getting a complete response in terms of their graft-versus-host disease symptoms or a partial response. A few patients early with stable disease, some of whom then lost disease control. But I think what's actually interesting is actually to look at the number of complete responders who actually increased with time after the single infusion. And so if we look at the overall responses that we saw, that we had an overall response rate sitting around that 45%, which is very comparable with the data that Hannah has just shown with the international case series. So being a pilot, our primary concern was of safety. The choice of nasoduodenal route resulted in no aspiration events, and only one of our patients, in fact, had a recordable bloodstream infection after their administration of their FMT, which was a coliform organism which may have been present in the FMT product. However, this patient had had infections with similar organisms previously, so we felt that it was possibly but not probably related to the FMT. But I think what we're really interested in, we've talked already about, okay, well, who responds and who doesn't? Can we understand that better? So in partnership with the Centre for Microbiome Research run by Jean Tyson at QUT and Jijing Tay, who's his postdoc, we've then gone on to actually sequence both the donor and the recipient microbiome at time points. So nicely, what we saw was that all of our donor stools clustered together on this principal component analysis. So obviously the donors were more like each other when compared to any of the recipients. And when we looked at the actual changes to overall diversity based on clinical response, we saw that, in fact, pleasingly, all of our complete responding patients did, in fact, have a nice improvement in their overall microbial diversity. However, that was generally not seen in the patients who didn't have an optimal response. So it really does show that the clinical response was related to an improvement in diversity. And equally, if you look at the overall sort of figures, some of our good responders, in fact, attained diversities which approached that of our healthy donors. So that was very gratifying to see. And I will just make note here of patient 3 in the blue, and there's some interesting data about that. There was someone who had a response but then lost it, which at this stage, if you look at overall diversity, it didn't seem to be related to that, but there's a bit of an answer coming up. So we wanted to understand then, well, what species, we've talked about who makes a good donor, what makes a good FMT, and what species are really associated with good and bad responses. So again, just looking at sort of the species now that are particularly driving those changes. It's a little bit hard to read on this, but the next slide will hopefully make it easier. We can see that the top, in fact, are the patients who had poor clinical responses, and these are the patients down the bottom who had good clinical responses. And there are certainly some recurrent species, and particularly Enterococcus faecium, that seem to be associated particularly with bad responses. So if we look at that pathogen particularly, and we look at our complete responders, in fact, it's quite gratifying to see that, in fact, all of them generally had a reduction or low prevalence of Enterococcus faecium in their gut microbiome. And then if we look at our patients who had less optimal clinical responses, in fact, the same wasn't seen. And that patient 3, who in fact had a good response early but seemed to still attain a good overall diversity, actually at the point that they lost their response is when they really started to see an increased prevalence of Enterococcus. So this really did seem to be a bad player. There were some lesser associations with Klebsiella and Lactobacillus rhamnosus as well. But this really was seemed to be a really key pathogen in being associated with the clinical outcomes. And when we looked in our donor samples, in fact, none of those had a significant abundance of E. faecium. So it really did seem to be a bad player. And so this is just another way really of representing this in terms of the bad outcomes, which were the recurrent pathogens that we saw compared to which were the protective ones. And so it's this type of data, I think, that people start to think, well, can we just provide a product that is more enriched for these species? And there are a number of groups around Australia that are really trying to pursue, and internationally, who are trying to pursue these sort of bespoke pathogen selected products. But ultimately, as someone who's interested in what this does to systemic immunity, we've really started to try and unpick this. And I must say that some of this analysis is just very early at the moment. But we looked at the proteomic profile in the plasma of all of the patients before and after the FMT to really try and understand, well, what factors are we actually influencing? Given this sort of gut immune axis, what factors are we actually influencing in systemic immunity that might be responsible for driving some of our clinical outcomes, particularly when you think about relapse and graft-versus-host disease? And so if you look at the factors that are down-regulated after the administration of an FMT, we can see some really common players in terms of T-cell functionality. So CD40 ligand, so a marker of T-cell activation, was reduced after the administration activation of the FMT, and as was PD-1, so one of the key components of the checkpoint pathway that is important. So this starts to, make us realise how relevant this could be for patients who are having checkpoint inhibitor therapy in solid organ transplant and solid organ malignancy. And equally, we saw upregulation of cytokines like IL-15, which are often associated with sort of more regulatory T cell function. So overall, it was, it's really our first step in, this was my first step in terms of looking at therapeutics that we could actually use to alter the microbiome to change outcomes after transplant. I think we can say that we were confident that we were able to use the lifeblood product safely in our allo-BMT population at the Royal Brisbane. We were able to see a really comparable response rates to a lot of the other international published series. We've seen this linked to the clinical response, which was linked to the actual changes in overall diversity and particularly of the abundance of Enterococcus faecium. And so there's still some data sets that I'm working on this. We're looking actually at the metabolome, both in the stool and the serum, to really understand what's getting translocated and what's able to affect systemic immunity. And then we'll look at the actual T cell phenotypes as well to understand how they may relate to some of the other clinical factors. But I think there's a lot to unpack, and there's a lot, and it's actually, as you pointed out, Bianca, this is an area that lots of patients really want to know about. There's a lot of demand to really understand how we can use these therapies better, and what therapies will be acceptable and desirable by patients. So obviously, transplant, we've got the work that would look to prevent immune complications, but the infectious complications are really significant as well. And there's a lot of work also going to understand how this affects barrier function, not just in bone marrow transplant, but also inflammatory bowel diseases. I think as we start to understand, particularly the link to systemic immunity, this is going to have real implications for how we treat a lot of other cancers, not just stem cell transplantation for hematological malignancies. And when we think about the ways that we can potentially do this, obviously we've talked about FMT. What about single strain organism preparations? What about just giving short chain fatty acids? So I don't have time to touch on that data today, but there are groups pursuing that. And a lot of my other work recently has been looking specifically at diet, and it was nice to hear about the work using inulin as a prebiotic to try and augment vaccine response. But we've got a novel prebiotic that we're trying to look at the role of in both our BMT, CAR-T and leukemia cell populations. And interestingly, actually there are some groups that are really keen to also look at the role of exercise in these type of context as well. So I think there's a lot, and as I said, there's a lot of patient desire to really understand these effects. So that's all I was going to talk about. There's obviously a lot of people who've been involved in this work, like obviously the funding through support through Lifeblood and also the RBWH Foundation, and to all the collaborators and people that I've worked with.